Good afternoon, everyone. I'm Janice Whitaker, CGNE Administrator and Community Liaison for the Tressa, Nieves, and Helen Diskovich Center of Geriatric Nursing Excellence at the Penn State Ross and Carol Nieves College of Nursing. It's my pleasure to welcome you to the Spring 2022 CGNE Seminar Series. This series is done in cooperation and collaboration with the Office of Outreach and Professional Development, as well as the Center for Nursing Research and Age-Friendly Care, PA. Today's seminar is entitled, "What Factors Influence Acceptance of Palliative Care Integration in Patients Living with Heart Failure?" And it will be presented by Dr. Evelyn Nieves, Assistant Teaching Professor of Nursing at our Harrisburg campus. Before this important and informative seminar begins, we do have some disclosures and announcements. So the Penn State Ross and Carol Nieves College of Nursing is approved with distinction as a provider of nursing continuing professional development by the Pennsylvania State Nurses Association, an accredited approver by the American Nurses Credentialing Centers Commission and Accreditation. None of the planning committee for this educational activity has relevant financial relationships to disclose with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. Participants with a valid RN license who attend the entire Nursing Continual Professional Development Program can earn one contact hour. Partial contact hours are not awarded. In order to earn contact hours, Zoom in and out times will be recorded, and the post-event evaluation survey must be completed within 1 week. As a reminder, this seminar is being recorded. If you have a question or a comment, which we will address during the Q&A discussion portion of the seminar, you can enter that in two ways. You can enter it into the chat feature, or you can use the raise your hand feature at the bottom of the screen, and Jenny will unmute you so you can speak aloud. We will be placing the post-event survey link into the chat following the lecture, and we will give participants a few minutes to complete it at that time. We also will mail it to you via email within 24 hours. It does need to be completed within a week of the seminar, especially for RNs that want to earn that contact hour. But we do ask that all attendees complete the post-evaluation form, as this provides us feedback on the seminars, as well as some data collection for the Age-Friendly Care Initiative. Nursing Continuing Professional Development certificates will be emailed to RNs, meeting all requirements within 1 month of the following seminar. If you have any questions or feedback for us, you can always reach us at cgne@psu.edu. So now I'd like to introduce Jenny Rank, CGNE Education Program Specialist. We are thankful that Jenny has joined our leadership team this year, and she will be monitoring the chat and the raised hand feature that I mentioned earlier. And at this time, Jenny will introduce our speaker.
Great, thank you, Janice. Dr. Evelyn Nieves is a diploma grad from Temple University East Campus, formerly Northeastern Hospital School of Nursing. She has 21 years of nursing experience from Pittsburgh to Philadelphia. She spent the last few years as a staff nurse working and is certified as a critical care nurse. She has been teaching since 2014. Dr. Nieves earned her Master's of Science in Nursing with a concentration in education from Walden University and a Doctor of Philosophy with a concentration in caring science from the University of Colorado Anschutz Medical Campus. She has been teaching at Penn State for 7.5 years. Now I present to you Dr. Nieves.
Thank you very much, Jenny. I am actually going to go ahead and share my screen. And I just want to ensure that everyone can see that. So this is actually a study that I completed. What factors influence acceptance of palliative care in patients living with heart failure, classes 2 to 4 and stages C and D. Heart failure affects 28 million people globally and 5.8 million people in the United States. The 5-year mortality rate is 59%, and roughly 20% of individuals will die within 1 year of diagnosis. There is no systematized effort to introduce palliative care early in the disease trajectory. Palliative care is a supportive, interdisciplinary approach that provides symptom relief and has the potential to enhance the quality of life, not only in those living with cancer, but also those with chronic life-limiting illnesses. This is the illustration of the American Heart Association designation of stages for heart failure, as well as the New York Heart Association classes of heart failure. And as you can see here, I'm actually looking at patients in stage C and D, which relatively corresponds to class 2 to 4. In conducting a literature review for this study, it revealed the following themes related to implementation of and acceptance of palliative care. The first theme was difficulty with diagnosis of chronic illness. Patients reported emotionally distressed experiencing feelings of fear, anxiety. Patients felt that they were burdening their families and felt socially isolated. Individuals also reported that they did not understand their illness was lifelong and terminal. A second theme that was found during the literature review was that healthcare providers' attitudes toward palliative care. They felt that treatment was centered and should be centered on management of symptoms and disease cure, and didn't take into account individuals' feelings and expectations of their diagnosis. Individuals felt that there was a lack of communication between providers, which eroded the trusting relationships between healthcare providers and patients. The third theme that I found was that healthcare providers' lack of experience. So healthcare providers stated that the term palliative care was confusing to them, and some providers had difficulty knowing when to use it. So for instance, they understood palliative care and that idea toward patients that had cancer diagnosis, but did not know or understand how to integrate that with people that were suffering from lifelong chronic illnesses. Therefore, implementing a strategy for not only palliative care integration, but perhaps also during the shared decision-making conversation is valuable to the relationships between patients and their healthcare team. The theoretical framework for this study was caring science and the hope theory. Caring science embraces the belief that our connection to one another is deeper than the physical encounter that is seen with our eyes. The caring science approach considers the connection to one another to include our connection with the universe. This universal worldview is inclusive, holistic, as well as humanistic. The foundational assumptions of the human caring theory are heart-centered, connected interactions termed curative factors and curative processes. The curative factors are the goals to achieve that connectedness, while the Caritas processes provide a guided action to promote connectedness. The purpose of the theory was to further define the uniqueness of nursing as a profession and discipline. Dr. Watson describes attitudes or Caritas processes as a framework for practicing professionally in nursing and beyond nursing. Caring science was coupled with the hope theory for this study. The hope theory is a positive psychological approach that considers if an individual can reframe their thoughts, they can live a more fulfilled life with little to no depression, anxiety, and loss of control. The interpretation is that hope thoughts are not just emotions or feelings, but a conscious reframing of thoughts that can be mindful and intentional rather than reactive. Pathways, thoughts are thoughtful, concrete routes and alternative routes created to reach a desired goal, while agency thoughts are motivation to follow those pathways and reach goals. While doing this work, Dr. Snyder classified individuals that could easily create new pathways as high hope thinkers, and those who could not create new pathways were stuck or low hope thinkers. Here you can see the purpose then of this study. Hope can facilitate living a more fulfilled life with better health outcomes by lessening depressive symptoms and increasing decision-making thoughts. An individual mindset that fosters hope is related to better quality of life and a better positive outlook on life and death. There is a gap between the positive influence of hope on heart failure. Palliative care has been shown to improve quality of life, as well as improve the detrimental symptoms of anxiety and depression in those living with heart failure. Individuals living with heart failure usually also struggle with depression and anxiety. Both depression and anxiety affect decision-making abilities. The autonomic dysregulation of neurohormones, which are present in individuals living with depression alone, are also involved in the compensation of heart failure. Depression interferes with decision-making abilities by impeding an individual's ability to make sound decisions. In a depressive state, the four abilities that are essential during the decision-making process, understanding, appreciating, reasoning, and making a choice, are disrupted. Early use of palliative care for individuals living with heart failure can improve quality of life and has already been documented as helpful for individuals living with terminal cancer. The research methods for this study were a parallel convergent mixed method study. This convergent mixed method study was designed with two parallel concurrent phases. The IRB was sought for a large teaching hospital with 5 heart failure clinics in central Pennsylvania and numerous online support groups. In the first stage, a prospective, exploratory, cross-sectional, quantitative study of individuals living with class 2 to 4 and stage C to D heart failure was conducted to explore which factors are associated with the acceptance of palliative care. As you can see, that quantitative numeric evidence up top. The second phase focused on the descriptive, interpretive, qualitative inquiry via phenomenological approach in order to explore the experiences of hope among individuals living with class 2 to 4 and stage C to D heart failure. Semi-structured qualitative interviews were used to reinforce findings regarding hope, goals, and palliative care acceptance. During phase 1, or the quantitative approach, of the formula of 10 cases per independent variable was used and yields a minimum of 80 cases. A total of 106 cases were collected for this study. Due to COVID-19, the clinics were closed and eligible subjects were sent to me via the cardiology nurse manager after giving patients a flyer with information about the study. I then followed up with the identified subjects via telephone for questions and/or enrollment in the study. For the online support groups, the flyer was placed on the online platform for participation in the study, and participants were asked to volunteer if they were interested. REDCap was used to collect and store the instrumentation data. The Adult Hope Scale, which is one of the instruments, is a self-report validated instrument consisting of 12 items, which includes 2 subscales to measure agency and pathways. The PHQ-9 is a 9-question self-report validated instrument used to identify depressive symptoms and severity. Both scales have been analyzed in many situations, demonstrated they can be used across a variety of populations and situations to elucidate what they say they can. During phase 2, the qualitative approach, this was a phenomenological, descriptive, interpretive inquiry. The role of the researcher here in this design is to rise above past knowledge and review the lived experience with a new awareness. A greater understanding of how individuals experience hope will add dimension to clinical care with nurses, physicians, social workers, and various healthcare professionals. The interviews took approximately an hour and were held via Zoom and recorded. Transcription was completed using Otter AI, and I reviewed it for accuracy. I had 3 aims for this study and 6 questions. The aims are identified on this slide. Aim 1 was to identify hope, social support at home, and depression, and how they influence acceptance of palliative care. The second aim was part of the qualitative strand, which was to describe the meaning of hope as experienced by individuals. And finally, the third aim was the analysis of aim 1 and 2, which was a mixed methods analysis. The following slides, we're going to go over the analytic approach of these aims. The quantitative analysis was begun after a number of cases was satisfactory. Then the data was uploaded to the statistical package for social sciences, SPSS version 27, for cleaning and coding. Little MCAR's test was completed and concluded that all missing data was missing at random. Overall, there were 99 valid entries for age, palliative care acceptance, and hours of support at home. 95 for annual income estimate, 83 for PHQ-9 total score, and 76 for the adult hope score. Then a binomial logistic regression was chosen to predict the probability of palliative care acceptance based on support at home, hope, and depression using the final 76 cases. A power analysis was completed for a statistical power of 80%. And at that statistical power, it yielded a minimum sample of 71 cases, and I had 76. Assumptions for binomial regression were assessed in order to prevent threats to statistical validity. Each test was properly satisfied, and so the results are statistically valid. There were 9 semi-structured interviews on this side, conducted ranging from 40 to 90 minutes in length. 56% stated they were being followed by palliative care. The interviews were transcribed verbatim using Otter AI, an automated transcription software application. An inductive and deductive approach was used to extract themes and codes, followed by a phenomenological reflection to look at the text in a more holistic fashion via 4 guiding elements: the space felt by individuals, bodily presence, time, and relationships with others. This allows a researcher to provide more depth and meaning to the lived experience. Finally, during the qualitative analysis, validity was measured by trustworthiness. Components of trustworthiness was assessed by credibility, dependability, confirmability, transferability, and authenticity. Each was satisfied in order to maintain trustworthiness of the study. Lastly, a triangulation mixed methods analysis was conducted using the lens of caring science. Triangulation is used to test convergence and provides a means to confirm research findings. Basely's 6-step method was used to test convergence. Mixed methods analysis provides a robust interpretation and explanation of a phenomenon. In this case, it was hope. The goal of such strategies is to mitigate investigator bias. At this point, we're going to look at some of the results, beginning with a quantitative strand. The observations for age had a mean of 54. Most of the participants were Caucasian, and 44% of the participants completed a bachelor's degree or higher. The most reported hours of support at home were 0%. However, 12% had over 9 hours of support at home. Here we can see the descriptive statistics for the study variables. A Spearman's Row non-parametric correlation test was conducted to determine the strength of the relationship between hope and depression. What that revealed was that there is a highly significant inverse relationship between the PHQ-9 and the adult hope scale. This correlation indicates that as the PHQ-9 score increases, the adult hope score tends to decrease. Once those descriptive statistics were analyzed, a binary logistic regression was conducted, first using forced entry and evaluated on an alpha of 0.05, suggesting that the PHQ-9 score, the adult hope total score, and support at home had a significant effect on predictability. The overall predictability of the model was 85.5%, and once the data was entered, the model predicted the yes category of palliative care correctly, 86.8% of the time. Next, a logistic regression was run using a stepwise analysis with backward walls criteria, which then eliminated the PHQ-9 as a variable because it was non-significant. The stepwise model was consistent with the forced entry model, meaning the adult hope scale and support at home did in fact have a significant effect on predictability. During the quantitative strand results, the minimum adult hope score was 15 and the maximum was 64 with a mean of 46. Statistical procedures ensured a good model fit, and once placed in the regression, the findings revealed that there was a significant positive relationship between hope and acceptance of palliative care. Therefore, investigating modalities to foster hope is not only beneficial, but seems necessary. Over 12% of the sample had greater than 9 hours of support at home. The study revealed that those who have support at home are 6 times more likely to accept palliative care. It is not surprising that during the interviews, all participants reported support at home via spouses, family, or friends. Some individuals even asked if their spouses could be included in our conversation of hope thinking, since hope does occur in a social commerce. Social support is essential for following through with agency and pathway thoughts. High social connectivity also produces better cardiac effects. Heart failure and depression are known to occur simultaneously. And stress is known to cause heart failure and depression. Individuals that experience the fight or flight response secondary to stress receive a flood of hormones, which raises heart rate and blood pressure. Depression is associated with less happiness and decreased life satisfaction. Depression was not statistically significant in acceptance of palliative care, but was highly significantly inverse to hope. Depression does not equate to the absence of hope. They are not opposing factors. However, depression does play a role in the inability to decide, which in turn affects hope thinking by stalling problem-solving skills necessary to create pathways. Let's look now at the qualitative strand results of the study. And here you can see that codes and themes that were extracted from the qualitative inquiry. A code is a short word or phrase that represents the summative essence of the data and allows for categorization. Themes are groups of codes that form one idea. So the three themes, I'm going to list and talk a little bit about them. The first theme is hope lends space for introspection. It describes their account of how they tangibly described hope if they could see it and feel it. The next theme, hope is transpersonal, is inclusive of how they contextualized hope or what it meant when they felt most full of hope. And finally, hope offers a future, grouped how they viewed what they can do now or what they will do in light of hope. Continuing with the qualitative strand results and answering question number 4, a descriptive interpretive phenomenological approach to discovering themes and essences in these accounts was used. And I further went on to name the interviews as a symbol of personal thoughts and reflections. Each of these descriptions attended to the participants' experience with space, bodily and physical presence, time and dimensions, and relationships to others as a reflective phenomenological exercise. For the sake of time, I'm only going to explain a few. George and his wife were brave, and I termed them this way because as I spoke to him, he was actually planning his funeral, and he had come to a period of peace. As we spoke, there wasn't anger nor regret, but the motivation to now plan his transition to the next. Hope helped him to be brave. Leslie was named Life is a Loop. And I named that because she described past bicycling before her heart failure. And after her heart failure diagnosis, that desire switched to needlepoint. And she was talking about how much she enjoyed needlepoint because it was something that she could complete. Hope is a destination for her. Jana and her husband, I named Deliverance because she was fighting heart failure since she was a child, and she never thought she would live to be the age she is now. Hope for them is transpersonal. A collage of the aesthetic is represented here. This aesthetic combines the words and pictures the participants used to describe hope. The word cloud was created using descriptors of hope from the interviewees. I chose the heart and the hands to represent the connection and healing. The interpretation of the heart and hands is, we cannot heal alone. We must be in connection to one another and our hearts to heal together. The surrounding photos are the aesthetic piece each participant shared during the interview, which represents hope to them. Again, only a few will be shared for the sake of time. Nina spoke about the rebirth of Yellowstone and the emotional sense it gave her to see and realize some of the things have to burn before rebirth can occur. Through introspection, Nina was able to see hope. During Grace's interview, she shared her struggles with her husband, who was dying of terminal cancer, and how her heart failure has taken a back seat. She also shared her need to serve her professional community. It sounds as if she's always running, and her aesthetic were sneakers, and she described hope as breathing better and being able to go outside and take a walk. Hope is connection. Marsha reminisced about her past painful divorce and her current struggles with her heart failure journey. Her aesthetic was her open heart scar. Here we see the mixed methods triangulation results and answering question number 5. The adult hope skill is based on 2 subskills, measuring agency thinking and pathways thinking. Hope thinking considers the individual's cognitive ability to create multiple pathways to meet a planned goal or goals, followed by the motivation or energy to follow the pathway. Scores of 40 to 48 are hopeful, 48 to 56 are moderately hopeful, and 56 or higher are high hope thinkers. The quantitative strand of the adult hope scale had a mean of 46, and the qualitative strand had a mean of 55. Caring science holds life as a sacred journey. And so in answering question number 6, I looked at how does caring affect hope thinking and the life world goal attainment of participants. Caring science is a sacred journey that all society takes together. Therefore, we have an ethical demand, a responsibility, if you will, to one another to aid each other in complete healing. It can be said that the Caritas process is the pathway to hope, and we all can motivate each other toward desired goals and better health states. The findings of AIM 3 affirm convergence of the data. Key findings of each of the data sets were used. Caring and hope are intertwined constructs that make holistic healing possible. In caring science, the pathway to hope is the demonstration of caring behaviors, such as authentic presence, enabling faith and hope, and honoring others' beliefs, which will open the door to reciprocal healing. The data sets are congruent and support hope as a caring science precept. The data sets also reveal the inverse relationship between hope and depression. Depression and hope are antagonistic, and as such, depression is detrimental to the positive attributes hope can offer. Triangulation of the methods and data reveal convergence. Now, with any study, there were some limitations to this study. First of all, the COVID-19 pandemic. And this actually impeded recruitment. And so, again, what I did with the recruitment is I petitioned the IRB to allow me to also recruit via Facebook support groups for heart failure. And it also, the COVID-19 pandemic contributed to the lack of diversity and inclusion in the sample. There was a limited response rate, and specificity of demographic information was a challenge. So in other words, for support at home, for instance, the question was yes or no. It was binary. Do you have support at home or don't you? It didn't have any more specific information to that. Same thing with palliative care. Did you accept palliative care or not? Necessarily, were you asked about palliative care, or when were you asked about palliative care? So again, there were some limitations to the study, as with any study. In conclusion, the implications of this study are vast and include implications for nursing practice, nursing education, and healthcare policy. The World Health Organization supports the uptake of palliative care and states that it is critical in the heart failure population, since 40 million need palliative care, especially in the heart failure population. This study has potential benefits to society and nursing as a profession. As the proportion of people in the United States with heart failure rapidly grows, the need for innovative ways to improve quality of life is essential to this population of individuals. The philosophy of caring science demonstrates a postmodern way of approaching nursing research and considers the relationship between the patient, the environment, and the nurse. The greatest need in palliative care is those with cardiovascular diseases. And that statement is put out again by the World Health Organization. As demonstrated in this study, hope is of interest in promoting palliative care acceptance. As a healthcare community, we must move past the disease-focused medical model and return to the holistic practice of mind, body, and spirit if we truly want to help individuals heal. Thank you very much, and I appreciate your time in listening to this slide set. I'm actually going to stop sharing at this point. And I'm going to hand it back to Jenny because I think there is a survey that they would like you to take before we continue with questions.
Yeah, well, Dr. Nieves, thank you so much for that very informative and interesting presentation. Your research is fascinating, and I think we're going to have quite a bit to talk about as well. But before we do that, as she mentioned, we would like to take a pause and ask our participants to complete the evaluation tool. Jenny has placed the link into the chat. So we're going to give everyone a few minutes to click on that link or copy and paste it, whatever your preference is, and complete that evaluation. So we're just going to pause for a few minutes, and then we will be back to engage in some Q&A and discussion. If you get done with the evaluation promptly, you can start entering some questions into the chat as well. So we'll just take a little pause right now to do the evaluation. Thank you. Okay, we're going to resume our seminar. If you're still working on the evaluation, please feel free to complete that as you can. We're also encouraging participants to enter any questions or comments they have into the chat feature at the bottom of your screen. And if you prefer to ask your question aloud or share your comments aloud, you can click on the raise your hand feature at the bottom, and Jenny will be keeping an eye on that so that she can unmute you to be able to share your thoughts aloud. So we're going to start with a question that was entered earlier. Given Black patients have the highest incidence and prevalence of heart failure and worse clinical outcomes, and I think you touched on this a little bit, Dr. Nieves, but what was the reason for not ensuring their prevalence in the study population? I think you touched on that when you touched on limitations, but perhaps you can expand on that.
I did. And I have to admit, I was disappointed, truly, because I was hoping that my sample would be much more diverse, because it's not just Black patients, but Hispanic patients also have a high incidence, which for me was the catalyst for doing the study in the first place, because both my parents have heart failure and my father died of heart failure, and I am Hispanic. So that was the catalyst for me. But because of COVID, I would never have been able truly to finish the study because I was not able to get into the clinics. So I was really left to people on Facebook that were willing to participate. And I had such small numbers of diverse individuals, if you will, that were, and every person that I knew I called, but again, the sample was purposeful. They had to have or have been told that they were this stage. And again, with the clinic, it was up to the clinic nurse, who then told the manager, who then told me. So it went through 3 different layers before it got to me, because I was not allowed to go into the clinic because it was closed. So hopefully that answers your question. We were talking about this with Janice and Jenny. I hope to be able to do something much more robust in the future, where I can make sure that the population is much more diverse.
Yeah, and I was going to ask you to, share with the audience what your thoughts are about potential future studies, where you would like to take this. And certainly sounds like increasing the diversity of the study population would be one of the goals of another study. But can you expand on that a little bit more? What other kinds of things would you like to do, moving forward?
I would like to also be able to not only diversity in obviously population, but also diversity in high hope and low hope. So one of the things that I was able to find here again is those people that were willing to participate. So it was, volunteer, hey, come in, to do this or whatever. They're generally going to be the more high hope thinkers, right? Because they generally are going to have more hope in a future, and they easily can reframe thoughts. Whereas in this study, I probably only had 2 that I would term lower hope, but still not low hope thinkers. So one of my participants was the one with the scar, whom when I say low hope thinkers, I'm talking about people that are stuck in an area, and she was very stuck in her heart failure diagnosis. And so she would be somebody who was a little bit more low hope, but I didn't have a lot of those people. So that would be one of the things that I would want to be able to include more of.
So we have a question from Olivia. Can this model be applied to heart failure patients that do not have a strong support network? And how can we better support heart failure patients that live alone with low resources? I know you talked about the importance of social support.
Yes. So if I can look at the question, I'm trying to get to it so that I can, because there was a lot in that question. I can't see it. So
Yeah, Yeah, there's actually two parts. So let me ask the first one first. So can this model be applied to heart failure patients that do not have a strong
Okay,
support network?
I see the question now. Okay, so
Okay.
yes. So now that's one of the things, again, that I feel like I didn't capture well in how I structured the question. So the question again was binary. Do you have support at home or not? So what I found in doing the interviews is that people consider support at home to be many facets. So sometimes support at home could be my neighbor that checks in on me, but I didn't ask about that. Sometimes support at home could be, somebody that drops off groceries, once or twice a week. I didn't ask about that. Or the visiting nurse that comes. I didn't ask about that. So I think that although they may not have a strong support network, I think being able to expand what the support network means is going to give us a better grasp of what we can do to facilitate a better support network.
Right.
The other question here was, how can we better support heart failure patients that live alone with low resources? That's a great question. And again, palliative care is something that the hospital should be able to provide, and that is going to help provide some of these resources. So looking at being able to provide this through Medicare and Medicaid services is going to be very helpful with those that have low resources. I'm not talking about palliative care where you go out and you get this on your own, rather something that a healthcare provider and hospital system can offer patients, as they do with patients that have cancer.
Right. So the palliative care component is huge. I think what I read in Olivia's question too was just the support network too. Are there ways that we could enhance an individual living alone, enhance their support network as well? So any thoughts on that?
Well, again, I think through palliative care. Palliative care is
Okay.
a vast, it can include very interdisciplinary work. So that would be something that, phone calls. I mean, there was a point in time, I'm not even sure we're still doing that, where patients, when they were discharged, we had discharge phone calls on the units, where nurses would call and make sure that the patients were okay at home. And I think that that's something that needs to be part of palliative care. One of the studies out of North Carolina, the biggest portion of the palliative care patients that increased their quality of life was because of the social workers that were part of their team.
I see. Yeah. So expanding and really using that interdisciplinary approach and looking at things like, those follow-up phone calls or telehealth visits or, caregivers going out into the home, a variety of interventions. So another question that's in the chat is, could you share more about the participants' clinical characteristics? How many participants were ventricular assist devices or on heart transplant wait lists? These could impact hope, is what this participant's wondering.
So the clinical characteristics, all of the people that were in my interview, so for instance, again, I had two strands, right? So I don't really know much about the people that just went into REDCap and answered my questions, right? What I know more about when it comes to clinical characteristics and was my qualitative section. So one of the actual Facebook support groups was a heart transplant group. So if any of them were part of the REDCap, if they selected yes, they were on palliative care, it immediately flipped them into my interview. So the majority of my interview candidates were on palliative care. So they were either on the heart transplant waiting list. And so if they had had the transplant, yes, they were the higher hope thinkers, right? Because they went further into hope. Again, looking at hope as a cognitive view and not a feeling per se, right? Ventricular assisted devices, I did have 2 patients that were on the ventricular assisted devices. The one was the one that had the scar. She did have a VAD, and I can't remember the percentage, but quite a few either had the transplant or were on a transplant list.
So one of the things that kind of popped out for me was when you were talking, I think your phrase was the caring and hope are intertwined. And it seemed like the slide you showed us related to implications for this study in terms of practice, education, and policy. Can you speak a little bit more specifically about, what you could see, in terms of in those areas, how we could enhance, caring measures that could impact hope?
So absolutely. And I think that in nursing practice, creating a space for hope, I think that nursing practice, when it comes to caring science and the caring science philosophy, it's not just about the connection or the relationship between the patient and the nurse, but it is also about the relationship between the nurse and herself and himself. So it is about being able to center themselves. It is about being able to be in an authentic place in order to go in and care for that patient in an authentic way and be able to be authentically present, right? So we use that word like a buzzword, authenticity, let's be authentically present. And it's like, well, what does that mean exactly? And it's just being able to intentionally, consciously pay attention, right? And be in the room. And so for practice, I think when it comes to education, that's really important to be able to teach our students as we move on, right? Teaching our students that it's not just about, these ABC things that we're talking about, but it is truly about taking care of the patient holistically. And how can we do that effectively? We first need to be able to take care of ourselves, right? So that's one way in education.
Yeah, that's a great example. Oh, I'm sorry, go ahead.
That's okay. That's okay. So for nursing practice, I think it helps that nurses can help patients create goals that are achievable. I think sometimes, especially in heart failure, right, we talked about ventricular assisted devices, again, medical management. And so the patient thinks that, all right, I'm going to get this ventricular, this VAD, right, this LVAD, and I'm going to live a normal life. But they can't. If they have an LVAD, they're not going to live the life they lived before. So again, being able as a nurse in practice, being able to help them find goals that are achievable are really important. And you asked me again about policy. I think that it's important with policy that we take this to another level in shared decision making. I think, again, that's a great place to start with this conversation about shared decision making because it addresses goals.
Yeah. Oh, those are excellent examples. Thank you for sharing that. So we have another attendee that asks, do all the participants know what palliative care is? Many healthcare providers can't define it correctly. Was this an issue? Did you identify that as an issue in the study that you did?
Absolutely. So again, it was my, in creating the study, one of the big things I learned, obviously, was to really be able to ask specific questions, trying to gain specific information. One of the things that I did was I just asked, is palliative care part of your treatment plan? Yes or no? I never asked, have you ever been asked about palliative care, right? And so I never gathered that. I know that when I did, again, my literature review, it was clear that palliative care is a very confusing topic, very confusing topic. So I wasn't really able to, parse out palliative care with only the people that I had interviewed with, right? So yes, the people that I interviewed, I absolutely was able to know, hey, were you ever asked about palliative care? Some had no idea. Now, all of the transplant patients did, because again, if you're going into transplant, it is an automatic, flag, an automatic tickler to palliative care, right? If you're on the transplant list, you're getting a transplant, you got palliative care on board, period. So all of them did. The patients that I interviewed that did not, they didn't know what palliative care was. The one person knew what palliative care was, but because her husband, who was dying of cancer, had palliative care, not her.
Right. So that person had some familiarity with it. And I think there is confusion, not only with the lay public, but even with healthcare professionals about the difference between the similarities as well as the difference between palliative care and hospice care. I think sometimes people think they're the same thing.
Yes.
So we're running close to the end of our hour. And on behalf of myself and Jenny, as well as our CGNE leadership team, I want to thank you so much for conducting this study that will help to inform, practice and many other things moving forward, but also for sharing all of this with us today. This was a very interesting seminar, and you gave us a lot to think about and a lot to look into. Really appreciate your expertise and sharing all of this with us today. So thank you so much.
Thank you. Thank you for the opportunity.
And to our audience, thank you so much for joining us today. If you weren't able to do the evaluation in the few moments that we gave you, you can complete it now. It'll also be sent to you in an email within 24 hours. If you're looking for contact hours as an RN, it does need to be completed within a week, and certificates will be mailed to you within a month. Thank you again to Dr. Nieves, as well as everyone that participated today, and have a great rest of your day.
Thanks so much.
Thank you.